So sir, we are live now. You can go ahead, sir. Thank you.
Hello and welcome to the expert crosstalk on empagliflozin. Multi-benefits and multi-indications by multi-mechanisms. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to APRA-REACH trial, does SGLT2 inhibitor can be considered as an important drug for HFrEF? To get the answer, let me introduce today's speakers. So today's speakers are Dr. Bhavesh Vajifdar and Dr. Manoj Chawala, and I'm a moderator, Dr. Shavik. Dr. Manoj Chawala is a director and consultant diabetologist at Lina Diabetes Care in Mumbai, Diabetes Care Research at Andheri. He's also a consultant diabetologist at Asian Heart Institute and Research Center in BKC and SL Raja Fortis in Mahim, and also founder president of United Diabetes Forum and also honorary visiting faculty at DY Patil Medical Sciences. He was also awarded as RSSDI Fellowship for the year 2007 and Fellowship Royal College of Physicians for the year 2019, and also principal investigator in various trials and also a course trainer in National Diabetes Education Program and many other programs. I welcome Dr. Manoj in this expert web talk. Our next speaker is Dr. Bhavesh Vajifdar. Dr. Bhavesh is a cardiologist at Meena Heart Clinic in Mumbai and also a consultant cardiologist at Lilavati Hospital, Holy Family Hospital, Karuna Hospital in Mumbai, and also several national and international publications in his credit. I welcome Dr. Bhavesh in this expert web talk, and I am handing over the session to Dr. Manoj to start with the presentation. Thank you. Yeah.
Thank you, Dr. Shavik. So it's good to have the different specialties and crosstalk, and I think this is one group of drugs which has brought together diabetologists, endocrinologists, and cardiologists and nephrologists as well. So it's good to see. And I also noticed that you have the Lina Clinic and the Meena Clinic coming in together for today's Empagliflozin talk. So shall I go ahead and share the slides?
Yes.
Okay.
Yes, sir. Yes, sir.
Of course, our conversation today focuses on the Empagliflozin. In fact, my today's presentation is almost like an overview and a revision for many about the Empagliflozin story over the last couple of years. A lot of you may be aware about the Empagliflozin data and the reason why Empagliflozin today has become the prototype amongst the cardio-safe or cardioprotective SGLT2 inhibitors. But here I am again taking everybody through the same story and re-emphasizing the data and the evidence for Empagliflozin. So I'll be speaking from the diabetologist perspective and then handing it over to Dr. Vajifdar to enlighten us on the cardiologist perspective. SGLT2 inhibitors have, over a period of time, strong published evidence for its data. But of course, there continues to be difference amongst the different SGLT2 inhibitors as to in terms of what is the strength of data that they have and how much of validation do they have. When we look at the data for canagliflozin, dapagliflozin, empagliflozin, they would have more than 500 multiple published evidences of different analysis, different randomized clinical trials, and also, of course, good real-world evidence over the last several years. You do a search for empagliflozin, which is available and approved only in India as of now. It has a huge limitation in the kind of data that it has. So basically trying to drive home the point that all SGLT2 inhibitors are not same. We also have had evidence from the Vertis CV, which was for ertugliflozin. Again, the Vertis CV showing that we cannot really equate the SGLT2 inhibitors, including the innovator SGLT2s like ertugliflozin, which did not show, or rather fell short of showing us any good cardioprotective data as compared to the other SGLT2 inhibitors. So getting back to the basics, what really is the role and the mechanism by which the SGLT2 inhibitors work? Today, we know SGLT2 inhibitors reduce the glucose reabsorption in the proximal tubule, which causes urinary glucose excretion along with the calorie loss and osmotic diuresis. In fact, this drug today we know works through many more mechanisms than just osmotic diuresis. There's a larger role of the sodium-hydrogen exchange systems and various other pathogenic or physiological mechanisms to its credit, and that's why the kind of benefits that we are seeing in terms of both renal and cardiac benefits of this drug. So the S1, when we talk about the SGLT2 inhibitors, the SGLT2 inhibitors working in the initial part of the proximal tubule does 90% of the reabsorption role, and the SGLT1s, which are more towards the latter part of the proximal tubule, just are active for 10%. So you basically need drugs which are more selective for SGLT2 inhibitors as compared to its action on SGLT1 inhibitors. Now, we look at the pharmacological properties of the available SGLT2, and when we say available, we are largely talking and distinguishing between the three established SGLT2 inhibitors. For empagliflozin, the therapeutic dose is 10 to 25 milligram, for DAPA 5 to 10, and canagliflozin 100 to 300. All of them are once a day administered drugs with or without food. The peak plasma concentrations again lie between 1 to 2 hours for most. Absorption with oral bioavailability, again 60 to 75% for all these drugs. So a lot of homogeneity in its characteristics for these drugs. Metabolism is primarily glucourinidation and no active metabolites for all three. Elimination, some features, some minimal differences between the hepatic and renal elimination. For empagliflozin, it has almost 50-50, if I can say, 43% through the hepatic and 57% through the renal route. For dapagliflozin, more predominant renal excretion at 78%. And for canagliflozin, the other way around, more hepatic elimination, 67% through the hepatic route. Selectivity over SGLT1 is, I think, what largely distinguishes these drugs and may be responsible for some of the different benefits that you see between this class. So for empagliflozin, the selectivity over SGLT1 is probably the best in class, as 1:5,000. We can see for DAPA 1:1,400, and probably the least in this is canagliflozin. Glucose excretion with higher dose. How much of glucose excretion? So you're getting 78 grams here, 70 for DAPA, and 119 for the high dose of canagliflozin. Now, let's again look at the data for empagliflozin. This is the pooled phase 3 placebo-corrected change from baseline in HbA1c, trying to establish again the efficacy of drugs like empagliflozin. We are looking at the data in blue for EMPA 10 milligram and in red for empagliflozin 25 milligram. Now, when you look at its A1c reduction capacity as monotherapy, you're seeing a 0.74 to 0.85% A1c reduction. When you look at it as an add-on drug, be it to metformin, to pioglitazone, to an addition of metformin and sulfonylurea as add-on to insulin, you see again anywhere reduction from 0.48 to about 0.64% reduction as an add-on drug. Let me remind you, this is an add-on reduction on the top of existing monotherapy or already dual therapy. So which is when you get this kind of reduction. You also look at the data in mild renal impairment, you're seeing a 0.52 to 0.68% further A1c reduction. You look at the data for body weight. As explained, the way these drugs work is they are causing enough glucosuria and calorie loss, have a capacity of almost causing, when we say 70 grams, we're talking about 280 to 300 calorie loss through the glucose excretion, urinary glucose excretion route. So there is expected to be some weight loss. Again, the data when you see for weight loss, you get a pool data of about 1.28 to 2 kg. You look more closely for monotherapy, you again get 1.9 to 2.2. As add-on to metformin, further additional weight loss of about 1.6 to 2. Even when you use it in patients on pioglitazone, it's negating some of the weight gain side effects of pioglitazone by causing reduction here. Similarly, in groups on metformin and sulfonylurea, and even in renal patients, you are seeing consistent weight loss benefits. You look at the change in systolic blood pressure. One of the other benefits we understand is reduction in blood pressure. And again, here you're seeing a pool benefit for blood pressure, about 3.4 to 3.8 millimeter mercury systolic blood pressure reduction. Now, which is significant. We, of course, have a cardiologist with us, who can re-emphasize, Dr. Vajifdar, on the significance of this 3 to 4 millimeter further reduction in systolic blood pressure, which is considered quite adequate and significant. We are also looking at the ABPM study in patients with diabetes and hypertension, and you're looking again at the systolic blood pressure. And you're seeing the impact of empagliflozin, both 10 and 25 milligram, as compared to placebo. So this is the baseline ABPM data, all overlapping pretty much. And then you see at the end of 12 weeks, both 10 and 25 milligram, beautifully showing reduction in the systolic blood pressure in the ABPM data across the 24-hour period, that you're seeing the reduction in the blood pressure. Importantly, this reduction in blood pressure not associated with increase in pulse rate, as may be seen in some other therapeutic agents used for diabetes. You're also seeing the diastolic blood pressure in the ABPM. So it's not only systolic, you're seeing some reduction in the diastolic, typically about 1 to 2 millimeter mercury diastolic blood pressure reduction, which again is considered significant. What about lipids? So there have been concerns about the non-favorable changes in the lipids on SGLT2 inhibitors. We are seeing the data here for empagliflozin 10 and 25 milligram. And you see there is some increase in the LDL cholesterol for empagliflozin. At the same time, you're seeing some increase in HDL as well, which is going to be helpful. In terms of triglycerides, there is consistent reductions as compared to placebo, which is again benefit. You look at the LDL to HDL ratio, again, no great change there. It's almost saying neutral effect on the lipid profile. But you look at total cholesterol, again, there is some increase seen with the SGLT2 inhibitors. Now, if I have to put all of this in a nutshell and again show you the effects of SGLT2 on glucose control, body weight, and systolic blood pressure, here it is, the entire data that I showed earlier in a nutshell, clearly showing its effect on A1C reduction, whether it is with monotherapy or add-on top of most of the other agents. There is very good data for empagliflozin. You talk about reduction in fasting sugar, again, consistent reduction across in all the groups. Body weight reduction anywhere between 1.5 to 2.5 kg weight reduction seen, and similarly has been the data for systolic blood pressure reduction. Now, this is an important slide which is talking about the safety aspect. So we're now looking at the pooled empagliflozin data in terms of its safety topics. We know there are some concerns because of the way these drugs work on the incidence of urinary tract infections, genitourinary infections. There are some concerns about volume depletion, postural hypotension, and so on and so forth. So let's really look at the pooled data. Urinary tract infection, well, as compared to placebo, slightly higher chances, especially in the 25 milligram group for UTI. Now, this is, again, we see this happening both in female and in male patients, the higher incidence as compared to placebo for UTI. What's important is when they've evaluated to UTI, the chances of higher UTI or pyelonephritis is actually much lesser. The chances of lower urinary tract infections have been what has been found to be the larger culprits, most of them responding to withholding the drug and standard treatment for urinary tract infections. What, of course, is more debilitating and a genuine limitation in our patients with SGLT2 is the occurrence of genitourinary fungal infections. When we talk about genital infections, we see this again much higher as compared to placebo. In both the empagliflozin 10 and 25 milligram group, we see much higher incidence, close to 7 to 8% of genitourinary fungal infections. Volume depletion doesn't seem to be much of a problem. We just need to be a little cautious, especially in the elderly and patients sometimes who are on other diuretics, where we have to be using this with caution to avoid volume depletion and leading to hypotension and falls and etc. in patients, especially the elderly ones. Number of patients with confirmed hypoglycemic adverse events. Is there a difference in hypoglycemia between the three groups? None at all. So clearly no hypoglycemia, no extra severe hypoglycemia, which is reassuring. Now, I quickly move to show the initial data for the landmark EMPA-REX study. This was a landmark day at the EASD a couple of years back when the data was presented by Dr. Zinman. Some of us, or many of us, were rather there in that hall in EASD when this data was presented, and everybody, all of us, were awestruck when we saw those graphs, which I'm going to show you, because for the first time in a diabetes drug, we had seen this kind of cardiac superiority data. So the EMPA-REX trial, which was the cardiovascular outcomes and that from any cause trial for empagliflozin as compared to placebo, in high-risk patients with diabetes on top of the standard care. What did we see as compared to placebo? For empagliflozin, the reduction in the 3-point MACE, which was cardiovascular non-fatal MI and non-fatal stroke. So for the 3-point MACE in the empagliflozin group as compared to placebo, you had a 14% reduction in the hazard ratio, which was found to be statistically significant with a 95% confidence interval between 0.74 to 0.99. Now, when we look at the individual MACE characteristics, cardiovascular death, again, in favor of empagliflozin as compared to placebo, you got a huge 38% risk reduction for empagliflozin as compared to placebo, 95% confidence interval staying between 0.49 to 0.77, found to be again statistically significant. You look at death from any cause, again for empagliflozin, you're getting a relative risk reduction of 32% with a confidence interval between 0.57 and 0.82, again statistically significant. And for hospitalization for heart failure, again achieving statistical significance with a relative risk reduction of 35% for empagliflozin as compared to placebo, with a 95% confidence interval between 0.5 and 0.85. When you look at this data, which is so impressive, it gets even more impressive when you start comparing it with the data which came over the years for other cardiovascular outcome trials. There have been many debates as to how empagliflozin has shown this magnificent reduction and the others have not been able to. But having said that, the proof of the pudding is in having it. And that's what empagliflozin has to its credit. The great evidence and reduction seen in the EMPA-REG found to be statistically significant in all these categories. Now, when you also look at the renal outcomes, you again, as part of the sub-analysis from the EMPA-REG, you look at, as compared to placebo for empagliflozin, the incidence of worsening nephropathy, again, in the group for empagliflozin, to be much lesser than placebo. So you're getting a relative risk reduction of 39% in favor of empagliflozin. You look at progression to macroalbuminuria, again, a 38% relative risk reduction for empagliflozin. For a composite of renal outcome as compared to placebo, for empagliflozin, again, you're getting a 46% relative risk reduction in the composite renal outcomes. So right from the EMPA-REG days, you had seen the benefits of empagliflozin, not only in the cardiovascular terms, but also in the renal outcomes. So in patients with type 2 diabetes and high cardiovascular risk, empagliflozin given in addition to standard of care reduced heart failure hospitalization or cardiovascular death, with a consistent benefit observed in both those with and without heart failure at baseline. And that was the larger conclusion, that this benefit was not restricted only to those who had heart failure, but even in those who had no heart failure. How early is this treatment benefit seen? Now, this is a post-hoc analysis of the EMPA-REG, which was presented this year at Chicago ADA, which was a virtual event again by Subodh Verma at Group, and which looked at how soon were the 2 points separating in between the placebo and the empagliflozin group when they looked at the sub-analysis. And when they saw the data as to how soon this was happening, what they figured out was, when they look at the time to benefit for hospitalization for heart failure, you're seeing this, you're looking at the data for first 100 days, and you're seeing this separation much earlier on. In fact, you're seeing this happening within the first, by day 17 itself, they could see this kind of separation happening for the benefits of hospitalization for heart failure. You're looking at a composite of hospitalization for heart failure or cardiovascular death. By day 27, you're beginning to see the difference between the empagliflozin groups and the placebo group. So this benefit, this has been very interesting. This data is just about 6 months old, and that is further added to the strong evidence for empagliflozin, that the benefits seen by these drugs are happening much earlier on, again telling us in terms of how soon can we use these drugs and how soon to expect benefits from these drugs when we use it for our patients with diabetes and any kind of cardiovascular risk. Cardiovascular safety trials are being conducted for each compound with the new classes. Now, this is the way it was. However, we know now that the US FDA has now stopped the advice for mandatory cardiovascular outcome trials and has classified the way the trials have to be done, including the high-risk population, the cardiac and the renal risk in the phase 3 program itself. So whatever cardiovascular outcome trials are ongoing will be the last few ones, but henceforth they will be changing the way they're asking for trials. But the US FDA and the EMA had mandated the cardiovascular outcome trials, and these trials have contributed immensely to our knowledge about these drugs and the evidence, and of course making our choice easier about what drugs should be taken and given the benefit to our patients. SGLT2 inhibitors modulate a range of factors related to cardiovascular risk. We know some of this, and some of the other pathways are more postulated and not even distinctly known, but things are evolving. So there is reduction in blood pressure and reduction in arterial stiffness, reduction in albuminuria, low uric acid, reduction in glucose and insulin requirement, reduction in oxidative stress, some evidence for query reduction in the sympathetic activity, reduced weight, of course, and reduced visceral adiposity. Some, as I showed, increase in LDL cholesterol and HDL cholesterol with reduction in triglycerides, but not something which is affecting the overall lipid profile. The exploratory data has shown that SGLT2 inhibitors may have multiple cardiorenal benefits. And all of these, on the basis of their cardiovascular outcome trials, are put here. Not always fair to compare the different CVOTs, but if I put the results shown for hospitalization for heart failure, CV death, and kidney outcome, I've already told the significant results seen in Empagliflozin. And this becomes important when you start comparing, as I was saying earlier. For Canvas, you're getting reduction in hospitalization for heart failure, not for cardiovascular death. For kidney outcomes, yes. Declare for dapagliflozin, again, reduction in hospitalization for heart failure and kidney outcomes, but not for cardiovascular death or the 3-point MACE. What is CV failed largely to show benefits beyond the hospitalization for heart failure. So that's where this gives the distinct advantage to empagliflozin through the data it has generated. And this, of course, has led to the guidelines being changed over the years. The 2018 ADA-ESD consensus report also mentioned that metformin need not be the first-line drug. So though some of the conventional clinicians like me would still want to stick to metformin till more evidence is generated. But clearly, post-metformin, your choice needs to depend on the presence of comorbid factors, and where there is a high cardiovascular disease risk, presence of hospitalization for heart failure or patients with heart failure or CKD, the choice of SGLT2 inhibitors is right up there. You have presence of ASCVD, you may want to choose a GLP-1, but where the patient can't afford GLP or not ready for an injectable, SGLT2 inhibitors become the choice. Similarly, 2019 ESC guidelines has again emphasized what they said a year earlier. The ACC-AHA has also spoken that post-metformin, you start considering SGLT2 inhibitors right up there. So clearly today that has seemed to be becoming the norm, where the SGLT2 inhibitors are being considered, and so has the ADA 2021 guidelines spoken about the need to use these drugs right up there, especially in the high-risk patients, to give them the advantage. So with that, I end my presentation and hand it back to the organizers to take us ahead with the cardiologist perspective on empagliflozin and SGLT2 inhibitors.
Hi, Dr. Chawala. It was really wonderful of you, and you have, nice synopsis. You have told us everything about not only about empagliflozin but the other empas, the other gliflozins, and I think there has been, by some coincidence, a lot of overlap of slides between you and me, because we know that some of the cardiovascular trials you've already spoken of. But nonetheless, I think it is really a very important topic, and hence I'm going to cover some of it and then leave it to a discussion between you and me and Dr. Shavik, and if there are questions from the participants, because this is now going to be really very, very important. This drug, as people say, is an endocrinologist or diabetologist drug coming into the cardiology forum, but I think it's going to be more than that. I think it's going to be with the physicians. It is going to be also probably with the primary care GPs in the long term. So I think it's very important for the physicians to understand what this drug does, what it does in diabetes, and what it does for patients with heart failure. And when there are both put together, what are the nice benefits that these group of drugs give. So with this, I think I will try to share some of the slides which I have made, and then we can have a discussion on what is the future of these drugs, how it is going to benefit us. So are my slides visible now?
Yes, sir, it's visible.
Okay, so I'm going to go on to my presentation. I will quickly talk about the role of empagliflozin in cardiology. Dr. Chawla has already given us a synopsis. And if really, if you would have asked me 5 years ago that would you be learning about diabetes drug, would you be interested in it? I would have said no, definitely not. What is my role? But now with this new data, with this wonderful drug which is coming in, we are really seeing the need for the cardiologist to also learn this diabetes drug for the benefit of their patients. So when we look at the spectrum of patients in cardiology, we know that one of the worst outcomes of patients in the cardiac portfolio is in heart failure. And if you look at this very wonderful slide from the Framingham Heart Study, one of the largest study which has given us a lot of primary data about the way cardiac diseases are. And here you see that heart failure in the center. Right. So you look at heart failure is such a high incidence compared to stroke or claudications or coronary disease, and this holds true for both men and women. Not only that, you see, we all know that heart failure has very poor outcomes. So even if the patient is asymptomatic, even if you have a patient who has hardly any symptoms, class 1 NYHA or class 2 with minimal symptoms, we know that if he has a low ejection fraction and he is in heart failure, symptomatic or otherwise, then the outcomes are really bad and the prognosis is worse than most of the cancers. So when we hear the term cancer, we are really very upset and the patient starts panicking. But if a cardiologist tells a patient your ejection fraction is 30%, it's not taken so seriously. But we know that the outcome of this patient is going to be worse than the outcomes of most of the other cancer patients. So we need to treat this well. And for this, we know that the treatment strategy for heart failure has been changing. 40, 50 years back, if a patient has heart failure, what would we do? We would give some diuretics. And if the patient is in acute heart failure and is decompensated, we start them on inotropic drugs. And like if he's in the ICU, then maybe some adrenergic drugs. And if he's in the outpatient, then something like digoxin. But then we came to know that this is totally wrong. And this is to be resorted to only in the last desperate situation. And most of the times we are trying to treat heart failure by reducing not only the congestion that is done by diuretics, but also by reducing the preload and afterload, reducing the sympathetic nervous system activity, by reducing the ACE, the RAS system activity. And by doing that, we reduce the heart failure mortality and morbidity. We know that drugs like beta blockers and ACE inhibitors, ARBs, are known to reduce cardiovascular mortality and morbidity because of heart failure. And now recently, in the last couple of years or so, we know that ARNI, that is sacubitril plus valsartan, has changed the treatment strategy, and we have a lot of benefits from this new drug. And lastly, we were surprised to see this wonderful drug, the gliflozins, which have come and they have been shown to have some cardiovascular benefits. Let us see. These are slides which have already been shown. So let us try to find out why it does that. So the simplest and the easiest thing which comes to our mind is this SGLT2, because they reduce the glucose reabsorption. So they are going to cause diuresis. They're going to cause glucoseuria, they're going to cause natriuria and fluid diuresis. So because of that, obviously, a person with heart failure is going to improve. But that's not the only thing. We know Dr. Chawla has already shown us all these beautiful effects of the SGLT2, which help in reducing the cardiovascular morbidity. Also, these are some of the possible, speculated mechanisms which SGLT2 inhibitors might be having, apart from reducing the cardiac preload, that is by diuresis. We know about that. It's very simple. But also because of the glucose-urea, there could be a shift of the metabolism to a ketone metabolism, which could be beneficial. There could be adaptive cellular reprogramming. There is an inhibition of sodium-hydrogen exchange causing natriuria. There is an improvement in the overall endothelial function. There is a trial now going on to try and prove this. And then there is also a reduction in the cardiac fibrosis, which ultimately ends into a better outcomes for patients with heart failure. Now, this is a landmark trial which is recently published, the Emperor Reduced, and these are the Emperor group of trials where you have Emperor Preserved and Emperor Reduced, and this trial was published this year. There were 3,700 patients, and they were divided into placebo controlled and empagliflozin taking patients. And over a median period of around 16 months, it was found that the heart failure hospitalization was less in patients who are taking empagliflozin. That means after patients taking empagliflozin, less number of patients went in for a heart failure hospitalization over 16 months as compared to those patients who were on a placebo. Similarly, the cardiovascular deaths in both the groups, if you compare, then the cardiovascular deaths were much less in the empagliflozin group as compared to the placebo group. Similarly, there was another trial by dapagliflozin last year, and there again 4,700 patients, a similar kind of a trial. And here the median period of observation was 18 months. And again, we find that in 18 months, if you are taking dapagliflozin, then your chances of you getting heart failure are less. Chances of you having a cardiovascular death are less as opposed to those people who are taking placebo. However, if you look at these individual trials, they were not really powered large enough with a large number of patients to kind of come to a conclusion about all-cause death and individual, parameters such as age, sex, renal function, patients who are on ACE inhibitors, different kinds of therapy and all. So subgroup analysis were not possible with that number of patients, though there were very clear-cut, hard endpoints of heart failure hospitalization and cardiovascular deaths were less, but we needed to understand a lot of other things. So there was this beautiful meta-analysis which was put this year, and they combined the patients from Emperor Reduce and the DAPA-HF trial. Of course, a little flip side is that the trial or the study was funded by Boehringer, which we know is the originator of one of the molecules. And here what they did is they combined all these patients and they tried to analyze in various multivariate analysis what was happening. And this was their conclusion. They found that EMPA and DAPA both reduced the hospitalizations for heart failure. And this was a consistent effect in both the trials. And they also improved renal outcomes. As Dr. Chawala said, that renal outcomes also improved. They also reduced all-cause mortality and cardiovascular death in patients with heart failure with reduced ejection fraction. That means ejection fraction less than 40%. And this they found was true for a large subgroup of patients, whether the patient is having EF, which is very low or slightly less, if the patient is having diabetes or not, whether the patient is in some NYHA class 2 or 4, whether the patient is elderly, whether the patient has renal dysfunction. In all these various subgroups, they found that EMPA and DAPA both were really good. And this was the conclusion of this meta-analysis. And that is what excites us cardiologists and prompts us to look into these drugs to try and improve the outcomes of our patients with heart failure. These are the slides which Dr. Chawala has already shown us, so I'm not going to see, just to tell you once again to emphasize that empagliflozin as compared to placebo reduces cardiovascular death, reduces death from any cause, really important, reduction of death from any cause, reduces your chances of hospitalization for heart failure. So this is really very important. It improves the renal outcomes also, and it does that quickly. That means you don't have to treat a patient for years together to get their benefits. Within the first 17 days, we start seeing that patients do better as far as heart failure is concerned. And within less than a month, you start getting the benefit of cardiovascular death. So this is really important, that in a short period of time for a large group of patients with different variables, these group of drugs are really effective and to improve the cardiovascular mortality and morbidity. So this is again shown by Dr. Chawala. Just to re-emphasize, there is a reduction of cardiovascular death and hospitalization for heart failure, and the kidney outcomes are also better. The guidelines have already been spoken to. So then this is again a very elegant chart which tells us what happens if you have an intense glucose lowering as compared to less intense glucose lowering. So here you see that if you have a better or a more intense glucose lowering, then all these trials like ECHOD, UKPDS, SWAT, all these things, they showed that you have a better results as compared to myocardial infarction and heart failure, resulting in hospitalization or even for death. So this is what common sense and we all understand, but this is what empagliflozin does. And by reducing your sugar levels, it's going to help in all these parameters. If you look at the different kinds of anti-diabetic drugs, now there are so many different kinds. For some, it is really out of my purview, but Dr. Chawala understands and probably will tell us later. If you look at the cardiovascular, the heart failure outcomes with different kinds of drugs, diabetic drugs, then you see that sulfonylureas did a better job, insulin does a better job. But if you look at pioglitazone, then of course you see that they are worse off. They worsen the heart failure problems. Similarly, if you look at DPP-4 inhibitors, which are nowadays quite popular, then they also tend to worsen the heart failure outcomes. But if you look at the EMPA-REG trial with empagliflozin and similarly the other gliflozin trials, then you see that they have a pronounced benefit for heart failure outcomes. So heart failure outcomes are best with this group of diabetes drugs. So the best would be empagliflozin, and then of course insulin, sulfonylureas, and GLP-1s may be having some benefit. And if you look at glitazones and if you look at DPP-4s, they are really having an adverse outcome. This again showing the similar kind of a chart of the benefits of empagliflozin over placebo in patients, reducing the patient events for heart failure outcomes. Another elegant chart about how exactly these drugs work. And here you see that it causes natriuresis. Dr. Chawala showed us how it does that in the kidney. And by increasing the sodium output, then because of the diuresis, you have a reduction in the preload, you have a reduction in the afterload. And because of that reduction, you have a reduction in the wall stress of the left ventricle. When there is a less fluid, you have a reduction in the interstitial edema. And if you have a better renal function, as is seen in those various trials, because of that, you have a better cardiorenal physiology. And with all these things, there is a better outcome for cardiovascular outcomes for patients with heart failure. These are again some of the Emperor studies, and this is the cardiovascular and renal outcome studies of Emperor and EMPA-REG. And just quickly, I'll tell you, this was a global study where they have studied both heart failure with preserved ejection fraction, that means EF more than 50%, and with reduced ejection fraction less than 40%. And after a 28-day screening period, they are randomized to either empagliflozin or placebo in both the sites, and they are followed up for 20 months after a treatment of 30 days with either of the group. And the primary endpoints was the composite of cardiovascular death or heart failure hospitalization. The secondary endpoints were two. One is the total or first as well as the recurrent heart failure, and second is the renal dysfunction. So there were 3,700 patients out of the total 7,000 patients which were screened, and they were with ejection fraction less than 40%, and they had a heart failure within the 12 months of enrollment. And if they had a coronary syndrome or a TIA or a heart transplant or valvular heart disease, then they were excluded. These were the various exclusion criteria. Important to know the salient features. This was a worldwide, trial, and not only whites, but there were Asians and there are people from Latin America. The ejection fraction was pretty low, 27%, and most of them were in NYHA class 2. Only 50% were diabetic. So not only all diabetics, there were non-diabetics in this trial. And they had some renal dysfunction in almost 50% of the patients, and they were on all kinds of medication. So just to tell you that there are different kinds of people in this trial, and despite all this, we see that the primary outcome of CV death and heart failure hospitalization was much lower in the empagliflozin group as compared to the placebo. So individually also, if you look, cardiovascular death was less in the EMPA group as compared to the placebo group. Heart failure hospitalization was also less in this group compared to the placebo group. So this is how we see, probably easier to understand. If you look at the primary endpoint, is a 25% risk reduction, and the p-value of less than 0.001, really very significant. Similarly, for recurrent hospitalizations, again, p-value less than 0.001, 30% reduction. Even if you look at the renal outcomes, then a very high p-value, a very low p-value, that means a really very significant reduction by empagliflozin. So similarly, I think I'm not going to bore you with all these details, but these are the charts to show that empagliflozin was better than placebo. When you look at cardiovascular death or hospitalization for heart failure, there's a difference. If you look at the renal outcomes, there is a difference. EMPA is better. If you look at total hospitalization, again, EMPA is better. So you see that it's the EMPA is really good and helps in so many different groups of patients. But what about the side effects? Obviously, there will be side effects, but if you look at this control with placebo, and here is empagliflozin, you see that most of the side effects are not really very bad. They are almost equally distributed on both the sides. You look at hypovolemia, you look at hypotension, you look at symptomatic hypotension, hypoglycemia, ketoacidosis, UTI, genital tract infections, and so on and so forth. And really not really very bad. And the side effects profile is not really very bad. In fact, so we are looking at a fairly safe drug with very good outcomes. And these are some of the secondary outcomes which came out of the trial. And I'll just go through them. So total hospitalizations are less if you are on empagliflozin. Your renal outcomes are better if you are on empagliflozin. Your all-cause mortality is better if you are on empagliflozin. Your possibility of developing a new onset diabetes are lower if you are on empagliflozin. Look at that. If you are pre-diabetic, but you going into the diabetes are lower if you are on taking EMPA as compared to placebo. HbA1c, of course, similarly reduces much more. There is a reduction in systolic blood pressure also. So you can see 2.5 versus 1.7, almost a 0.7 millimeter difference. And the confirmed hypoglycemia, again, is not significant, though we think that because of so much of glycosuria, you could probably end up with hypoglycemia. Yes, you do if your patient is already also on sulfonylurea plus this empagliflozin plus an insulin, then of course you are the possibility of hypoglycemia higher. But if your patient is only on EMPA, then the chance of a hypoglycemic event are really very low. So the end point, what does it tell us? That empagliflozin is really a very good drug and improves the outcomes in the form of a reduction in the heart failure hospitalizations. It reduces the cardiovascular deaths, and it's beneficial in so many other secondary endpoints, including renal parameters. And hence these drugs become really very potent armamentarium for us. So with that, I think I will end my talk. We can have some discussion. We have some time. Probably Dr. Shavik will guide us through some question and answers. But these are some of the things which maybe you would like to discuss. I will leave it to Dr. Shavik to decide that.
Yeah, thank you, Dr. Bhavesh, Dr. Manoj, for your wonderful presentation. We have two questions from the audience. Okay, the first question is for Dr. Manoj. Dr. Manoj, according to there is a question. Yeah, among DAPA, canagliflozin, and empagliflozin, which should be the preferred choice in diabetics with impaired renal function? And why?
So it's a question from somebody who seems to be following all the data, which is nice. So till recent times, though EMPA-REG sub-analysis had shown reduction in the renal outcomes, which I showed, the stronger data in terms of more dedicated renal trial was only through the CREDENT study for canagliflozin.
Yes.
Following that, of course, we had the DAPA CKD, which is again shown similar or better reduction, not only in the renal, but also in the cardiac parameters for dapagliflozin. The EMPA renal was always a part of the EMPA-REG and the sub-analysis after that. And the dedicated outcome trial would be again released in a while. Having said that, in patients with renal dysfunction, as of today, I would say the choice is pretty open between the SGLT2 inhibitors. The renal benefits, if you go back and see the 3 cardiovascular outcome trials, be it EMPA-REG, be it CANVAS, or be it DECLARE, all 3 in its renal outcomes have shown reduction. Of course, when we go by the dedicated renal outcome trials, the strength lies with DAPA-CKD and with CREDENT. So you give that credit to the 2 other molecules. But clearly, let's also not forget that most patients with renal dysfunction are likely to have a cardiovascular comorbidity. And most patients, even with renal failure, eventually succumb to the problems of cardiovascular death, as Dr. Vajifdar would agree. So hence the choice needs to be with a drug which has shown strong cardiovascular reduction. And hence, having said that, you have a patient with pure renal without any cardiac, it's going to be difficult. You may choose the other ones. But if you're going to put all that in a perspective, diabetic with renal dysfunction, with coexisting cardiac, I think the strength largely goes in favor of empagliflozin with its strength of evidence there.
Yes. Thank you. And there's another question, Dr. Bhavesh. Vajifdar, can we prescribe SGLT2 inhibitor in patients without established CVD or having multiple CV risk factors?
Okay, so now we are looking at 2 sorts of indications for these drugs.
Yeah.
One is the cardiac indication, and other is the diabetic indication. Okay, so if you are looking at the cardiac indication, then you have to have either a person with an established coronary or a atherosclerotic cardiovascular disease. That means the patient has had a myocardial infarction, has an angio which shows this. He has had angina. He has had a CT coronary angio. He has that is established or he has got a stroke, a thromboembolic stroke or atherosclerosis somewhere else in the body. That is one. Or you have multiple risk factors. That means you are high risk for coronary artery disease. So if you have high risk for coronary artery disease, means you are diabetic, you are elderly, you have a strong family history, you have a dyslipidemia, you are a smoker, you have hypertension, you have renal disease. So when you combine all these, and there is what we call as an... So, sorry? Hello?
Sorry.
Can you hear me?
Sir, yes, sir.
Yeah, okay. So if you have a person who is high risk cardiovascular cardiovascular events, then again that person becomes a candidate for empagliflozin therapy. You see that some of the guidelines also say that you can use these drugs even regardless of the HbA1c. So even if you have a HbA1c which is lower than 7, but if you have an established coronary disease or atherosclerotic disease or a very high risk for coronary, then you can still prescribe empagliflozin or a similar drug to these patients. Of course, this is really a new concept, and it takes some time to sink into everybody. I think I would like to ask Dr. Chawla, because I'm also just beginning to start use these drugs in this group of patients. I'm still not using them for people who have an absolutely normal HbA1c. So if your HbA1c is 5.5 or lower, and in those subgroup of patients, I have not initiated this drug for their cardiovascular outcomes benefit. Probably we should, I am not sure, but patients who are in a borderline zone like 5.5 to 6.2, 6.3, where you would otherwise not want to give an anti-diabetic drug, these patients surely we prescribe this drug. Dr. Chawla, what is your take on this?
Yeah.
In terms of using it in
patients who are having HbA1c of 5.5 or less, their cardiovascular benefit.
Right. So though these drugs have shown no real hypoglycemic tendencies, and they have shown improvement, the fact is that Dr. Vajifdar would be the first one to share the experience, as I don't see non-diabetics. So
yes, so we do see non-diabetic patients, and as I said, I think it's a beginning. But as the time goes by, I think I'm now being more and more bold to use these drugs, because we see heart failure is really something which has a very poor outcome, and whatever little we can do, we should do for reducing the mortality and morbidity of these patients. So as of now, so if you were to ask me a few months back, I would use these drugs only for diabetic patients which had cardiovascular problems. But of late, I've been using them also with something like what you may call pre-diabetic subset, but with a completely normal HbA1c. I have not started using them now, but perhaps in the near future I might. I will wait for some more time before I start doing that. Yeah.
Thank you. There is no more question. So we have some.
So I maybe I can learn, because Dr. Chawla is here, and
better actually.
we are always
from Dr. Chawla.
Not too good at reading the basics, and we want to just look at the guidelines or look at the major things, and you start using them for their benefits. So I would like to take advantage of the fact that Dr. Chawla is there. He seems to be really very well read. And so Dr. Chawla, what is your personal experience of using the different gliflozins? Are you for these kind of cardiovascular or patients, do you have a little edge over the other or something like that?
Yes, thanks for that, Dr. Vajifdar. In fact, I did speak in this topic, in fact, debated at National Diabetes Forum just recently, so I'll be happy to share what I said. Clearly, when you look at the SGLT2 inhibitors, there are some aspects which can be considered as a class effect, and there is some homogeneity in its benefits. When it comes to the glycemic benefit, it seems to be more homogeneous amongst all the SGLT2 inhibitors, including remogliflozin, if we say. When we talk about calorie loss and the weight reduction benefit, again, seems to be more homogeneous across the data. When you look at hospitalization for heart failure, though we don't have any data for remogliflozin, when it comes to the other four, including ertugliflozin, it seems to be, again, largely a class effect that you're seeing reduction in the hospitalization for heart failure. But that's where the homogeneity seems to be ending. When we talk about the rest of the benefits, so today, clearly, when we talk about the cardiovascular benefits, we talk about especially the MACE benefit, which across the trials have been shown to be largely reduced in the EMPA-REG for empagliflozin. You saw a 3-point MACE reduction even for canagliflozin in the CANVAS trial, but no benefits again for cardiovascular death. And of course, for dapagliflozin, you didn't see any of that happening in DECLARE. Yes, we do understand that all these trials were largely done to prove non-inferiority and safety of the drugs. Having said that, the kind of data which came out for empagliflozin is what led to the US FDA giving it a labeling to be used as a drug for cardiovascular protection. Now, of course, these trials have different population. In an EMPA-REG, you had 99 point some percent patients, which were largely considered as secondary prevention, and then you had different patients in different subsets. But when it comes to interpreting that data and putting it to our use in clinical setting, as we said today, when you have a patient with diabetes and cardiovascular comorbidity, clearly the first thing that would come to a mind of a diabetologist, endocrinologist, and definitely a cardiologist in the strength of its evidence is empagliflozin. And that's the trend that we have also seen. Now, when it comes to heart failure, maybe today a cardiologist would be looking more at dapagliflozin with the data coming in there for dapagliflozin and the noise level today that we have, of course, for dapagliflozin, with dapa also going generic. Yes. So clearly, it's the perspective and what you attach with. So till some time back, for cardiovascular protection in general, empagliflozin. For renal, canagliflozin was given an edge. For heart failure is where dapagliflozin came in. Of course, a lot of that is changing. Also, when we talk about ASCVD reduction, let me remind that the data isn't that strong for any of the SGLT2 inhibitors as it is for a GLP-1 receptor agonist. Now, having said that, even though a cardiologist would know that, I haven't seen much of the cardiologists using GLP-1 receptor agonist. One, because of its side effect profile. Two, of course, its cost. And third, the fact that it's an injectable therapy. We, of course, have the oral semaglutide now being approved in India as well. Rybelsus is available in the West. In India also, the DCGI has approved the oral semaglutide and probably will take 6 months to be available. So for ASCVD, you have a greater little leaning data towards the GLP-1s. But in the absence of being able to afford them or tolerate them, then the SGLT2 inhibitors comes in. And when that is the aspect of ASCVD, cardiovascular death reduction, empagliflozin clearly seems to have the strength of its evidence. Right. So when it comes to those benefits, I think all of you will clearly go ahead and use EMPA more than others.
Right. So there are some other points which come to my mind regarding this. The favor for EMPA or maybe DAPA or something like that is the ability of being able to use this drug even in an acute heart failure. So if a person is admitted with an acute heart failure or just coming out of an acute heart failure, you would be happy to give a drug like EMPA or some gliflozin so that you are going to have diuresis and it would be better. Also, it's simpler for to administer, like as I told you, cardiologists are not too good into all these nitty-gritties of pharmacology, but you have a very simple dosing patterns, once a day drug, a single dosing regimen, 10 or 25. There is a minimal drug-drug interaction with the commonly used drugs. And we see that hypoglycemia, hypovolemia, hypotension are not really as much unless there are some other comorbid conditions. Like if a person is hypovolemic and then you give them this drug, then you're going to have hypotension. And if you are going to be using insulin and sulfonylureas along with it, then hypoglycemia, otherwise very safely tolerated. And the dreaded side effect of UTIs and genital infections, also we see in practice not so common. And hence that is why we are a little more comfortable trying to use empagliflozin or similar drugs for our patients.
That was interesting, Dr. Vajifdar. You're saying that in patients even with hospitalized for acute heart failure, are the cardiologists getting comfortable using SGLTs?
Yeah, we are just started to use them. Yeah.
Okay. Because the general dictum and belief was that in hospitalized patients, for various aspects of dehydration and hypotension, it's best to avoid this and use it more in stable.
Understand. There was, if you look at the analogy of drugs like say ACE inhibitors or beta blockers, and lately now ARNI, the sacubitril. So all of them initially when they came, they were supposed to be used for stable heart failures. And, once the patient is really out of the acute stage, totally stable, and then you start beta blocker, then you start, ARNI. That was how they came in. But slowly they graduated, and as we build confidence in the drug and we are able to understand the dynamics of the drug, probably we are then using them in more acute, more and more, acute. I'm not saying a person who is, in frank LVF, we are going to give this, but a person who has been admitted with, say, class 3 symptoms, who is now just coming out of the acute episode, I think just like we add a beta blocker, just like we add a ARNI more earlier now, similarly, I think I have started using it, of course, in a very small way, but I think probably because of the various pharmacological properties, probably it will be a drug where if you use it judiciously, then probably will have some benefit before the patient gets discharged. If you start these drugs, probably would be a right thing. Of course, I am not looking at patient who's come immediately with an acute left ventricular failure, and that is not the patient we are going to use it on. Yeah.
Very interesting. I think that may be the way ahead. That's very interesting to know.
Okay. Thank you, sir. We are running out of the time. So this is a never-ending discussion, Empagliflozin and SGLT2 inhibitor. So thank you, Dr. Bhavesh, Dr. Manoj, for a wonderful presentation and sharing your valuable experience. And on behalf of Lupin, we thank you. Take care in this pandemic and see you in the future meeting. Thank you, sir.
Bye-bye.
Thank you, everybody.
Good evening, everyone.
Bye.